Thank you, Eric. Thank you, the whole committee, for inviting me to lecture to you about the Pecs Blocks. And I was here last year talking in a different way called the diffusion blocks. Now, very interesting lectures so far, and I'm sure the next will be equally interested. From my point of view, this is a completely different approach. And when I was thinking about giving you this lecture, I thought about giving you analogies. Analogies, so you can perhaps understand the way I was thinking when I understand these blocks. I will try to make an analogy between the discovery of America and these blocks. And then perhaps trying to make it interesting for you too, because maybe you had something to do with it. The first 5 minutes just to talk about. I'm from here, although you just said that I'm from the Emirates right now in Abu Dhabi. In reality, I'm Galician. I'm from the northwest of Spain. So Atlantic coast, yeah. And it is in the Atlantic coast where all of us, we knew for many, many years, and there are lots of evidence, documentation, that there were some guys in there as far as the 1400s that oral tradition said they were called Colon. Yeah? When you look now at the discovery of America, 450 DNA tests, and nobody knows where people are coming from. All the Italian families were there and negatives, all the Mediterranean were there and negatives. But the fact is that a Mediterranean sea sailor, that means at the back, it is very unlikely from an anesthetist's point of view to discover America. When you look at the map, it has to be somebody from the Atlantic coast, somebody from the front who then discovered America. And if you look at these kind of signs that you get in very, very old buildings in the coast of Galicia, in there you can see the names greeting from 1400s. It says Juan de Colón. Yeah? But the most interesting thing for you is that if I just move a little bit more further here, this chapel was discovered not long ago, a few years back, and if you look closely to this chapel, was hidden behind some wood things. It was saying there that that chapel was built by Colón in 1400s. And you can see here that the Colón thing, they have erased one letter. Well, the fact that it was erased, that letter, because it's supposed to be originally from a family of coursers that came into our region from France. So perhaps some of the DNA tests should be taken between you guys. Maybe someone in your family is part of the history. But anyway, from Abu Dhabi now, leaving Galicia behind, you got the Louvre, so you are more than welcome to come and visit it. If you got some time off just that you can spare, we'll be delighted to see you there. Now, when it comes into talking about Pecs Blocks, I like to start saying this. Somebody is asking me, is this the future block? And I always say, no, it's not the future block whatsoever, because it is the present. And it has become the present for quite a long time by now, since I described this in 2011. And the reason why it's the present, it's a little bit of what you just seen so far. It's because these blocks that you done there, they are simple blocks that are done with linear probes. So anyway, this is just to tell you that there's no conflicts on the interest in my lecture. And the concept of these blocks is also branched in a very French concept that is all for one and one for all. And I will go back to that kind of iconic way of saying it. The concept of the thoracic blocks as such, right now, for all of you that you are here, is this. Thoracic blocks are blocks that you can say, I can do that. My perception, and it's been for a while, when it comes into paravertebral blocks, and before all this, before 2011, I used to do lots of paravertebral blocks myself. And I used to teach an international level in paravertebral blocks and do this and that. But my idea was that it was not a block that everybody could do. And it was not a block that after teaching it, everybody was going back home thinking, I'm going to do that tomorrow. So it needed a completely different approach, a more logic approach, a more anterior approach, like the column thing. I had to build the blocks that were everybody in this audience could be comfortable to do without hesitation. And the hesitation is not there because they are simple blocks. And these simple blocks are based in, instead of just trying to locate nerves, that even the paravertebral doesn't do that, is that it was all about locating planes. And the thought was, if you locate a plane and let the local anesthetic to do the job, the local anesthetic will reach the nerves. So it was all about putting the needle in the right point, but not this time the right point meant next to the nerve. So equally, by locating a point that was good and easy to perform, it was needed that we were avoiding potential effects of it. So the second premise, the second idea was to avoid problems. And the third one was to use the best technology we had so far. And the best technology was telling us the more superficial you are, the better the resolution. So the better the resolution of the image for you, the easier the block will be. So we needed to find a block that was easily done with very high resolution and with no side effects. So that's how we came up the idea of these 3 blocks. Sorry, it's going a little bit slow. So far, the definition of these 3 blocks, 1, 2, that is, I'll explain you what are the difference between these 3 and serratus blocks. It was the idea to provide you with a battery of easy and reliable superficial blocks. Yeah? That doesn't aim to block the whole thing, but it aims to do the job. It aims to use the hemithorax to a point that is enough for you to get away with the problem of these patients having pain or having all the type of complications that can delay discharge. So they were designed to be the alternatives to the paravertebral blocks. That's why I'm here. Yeah. And it was not at this stage, and it's not at any stage for me just to try to convince you what is better and what is not. This is a decision that you have to make for yourselves. So the blocks were performed not that far away. 2011 was the first time I decided to write a letter about it. Yeah. And if you compare that, we're just talking about 3 years. Okay? We've been just talking about Pecs blocks for 3 years. The same way, we've been talking about top blocks for 7 years. Does it make you think why paravertebral blocks have been with us for 50 years? And it's still not quite there. Yeah? Still, you don't get the impression that you're not comfortable enough to perform them. Because, of course, I mean, there will be some of you that are really, really good at doing it, but the reality is it's half a century trying to sell us a block. That is good, okay? The key issue about all this was here, is when you look at the anatomy, the cross-section anatomy, to me it was very, very, very easy to realize that my key nerve to block was the lateral intercostal nerves, the lateral branches. And I had to locate that point. And the inspiration came from the previous block, that was the top blocks and the QLB blocks. So once again, started doing the graphics, cross-anatomy graphics with some of the muscles. Apologies for this presentation in Spanish, but it's pretty obvious what it means. And it was all about triangles. You can see that most of the anesthetists these days, when we teach about ultrasound, we love to use triangles. Our triangles, they seem to be, all of us, quite similar. You know, so that was the triangle that I had to find for it. Because the triangles gives you the limits, it gives you the boundaries and the reference to find out the optimal points where you have to put your local. And this is a schematic representation of what you see every day. When you go into your theaters, back to your theaters, and you see surgeons operating in all this surgery, this is what they do. They take fat away and they leave you with that. And then you just pick on it and you put your nose on top of it and you start asking, what is this, what is that, what is this? Well, there you are. If we can imagine that the breast is here, look at this picture here. The head is there and the arm will be there. Okay, you can see the muscles here, pectoralis major and minor there. And then you got this big hole here, that is the axillary compartment. In the axillary compartment, you have lots of structures, But when you look at it, immediately you realize that these structures, they kind of cross with each other. So it is very logical to think, okay, I'm going to stick my needle in the middle of the cross. Put it in there and let the local anesthetic do the job. Hopefully, I will get to all the points at the same time. So you can see here our reference, vascular reference, the axillary vein. That is the one you can see from the axilla up. You won't see the axillary artery. And you can see a very important, interesting nerve that is intercostal brachialis nerve, the one that the surgeons tend to cut many times. Over here, the rib cage with the serratus muscle. And on top of it, the long thoracic nerve. And then at the very back, dig into the back, is the thoracodorsal nerve. Now, if I go back now into this very familiar cross-section for you of the Visual Human Project, and I'm trying to show you and explain you what the logic behind all these blocks, because when you do something, you have to provide with the logic for the people to believe in you. You can see here two major compartments. A pectoral compartment that is here with two big muscles. Yeah. And that will be the essence of the Pecs 1 block. Breaking up this plane, open it up or hydrodissect it up, and let the local anesthetic to soak all that network of nerves that will innervate the hemithorax. And it did the job, and it does the job. And I think most of you that you have tried it, you know that it's got an effect in it. But it was not complete, so we had to carry on developing all the ideas. So the whole idea was, okay, we got the pectoral compartment, but we need to get to the intercostal nerves. We need to get into the axillary compartment. So the axillary compartment, by logic, is just meant to go one level down. So if I go now here and show you in the numbers, that was the pectoral 1 or Pecs 1 into the pectoral compartment. But by logically speaking, if you want to get into the axillary compartment, you block your pectoral. Obviously, it's good, it works. We're going to do it. There's no harm in doing it. But you also go deeper down and you reach the axillary compartment. That is where all your other nerves are, mainly the intercostals, that are the ones that go to give sensation to the breast. So you can see here that the logical point will be somewhere under the pectoralis minor. That anything under pectoralis minor is the axillary compartment. If you look at back doors, and the ones that we like computers, we do that all the time, you always find, okay, this is fine, I got my anterior approach into this compartment, but what is the back door into it? The back door is given by two big muscles there. An ultrasound can help you to see muscles very easily. It's something you can see easily with an ultrasound is a muscle. The only thing you need to know what muscle you're looking at. So two big muscles there, latissimus dorsi, and the serratus back again. So my back door will be in between these two muscles. It's that simple. So one compartment for the pectoral compartment, there, Pecs 1. The second compartment is the axillary compartment, and the third one will be the serratus. So that's the solution, trying to give a complete battery of blocks for you to decide which one you're going to go for and for what. And all of them simple, easy blocks in which the reference are muscles. There's no bony windows. There's nothing dark into all this. Everything is crystal clear. But also the beauty of it is in the fingers of the surgeons. We really don't like surgeons very much. And the older you get, the less you like them. But the funny thing about surgeons, sometimes they do something useful for us, is that they break anything. Whenever they start digging around and cutting around, what they do, they open up spaces, isn't it? By opening up the spaces, what they have created is a big single compartment. And what it means, it is up to you to choose which is the optimal point of injection to reach to that compartment. And that it comes into my phrase that all becomes one. So once the surgeons put their fingers into the surgical site, all become one. So I'll give you the idea for the optimal point of injection. So let's go into the 3 blocks, our icon. These are the blocks as such, and you can see the evolution, and you can see how is the path and how is the logic behind. It's very simple, moving from anterior towards posterior with different anatomical images or patterns that you can easily recognize. One with the muscles, two pectoral muscles, one with the pectoral muscles just at the edge with the serratus underneath, and another one with the latissimus dorsi and the serratus. And to simplify things for you, because you need to really memorize something, and the easiest way of doing it is with these graphics. And in here, I'm going to give you magic numbers for you. And there's something you can need to keep in your mind about these numbers, so these local aesthetics that you use, because invariably in every lecture I get the same question about the volumes I use. It's going to give you the magic number that is always the 2. Yeah, it's the 0.2 mils per kilogram, either for the PEX 1. If you go for the modified one, or PEX 2, don't forget to leave those 0.2 mils per kilogram in between the pectorals in the pectoral compartment. There's a huge debate about how pectoral nerve works, so we're going to block them anyway. We need them. Yeah, but also get into the axillary compartment and put another 0.2 mils per kilogram. And then we can debate about where do you put it, because once you are in the axillary compartment, it does not really matter. You are in the axillary compartment, the local aesthetic diffuses all around the serratus. Yeah, you can call it anything you like, but it's the pectoral 2 or modified PEX 1. If you go posteriorly into the SPV, in there, which you can see also again muscular patterns. You put the local aesthetic above the serratus. You can do it underneath too, up to you. Yeah, but they all communicate, and this gives them similar patterns. And once again, you go into your 0.2 mils per kilogram. Just to simplify it, to keep it really, really simple. Right. Now, this data is from one of my trainees and one of my colleagues now, an amazing guy with lots of enthusiasm, that is really working now is, okay, we know these blocks work. We do know, but how do these blocks work? That's the question right now. Because when people trying to sensory map in these blocks, interestingly, 33, they get a sensory mapping, a positive sensory mapping, but 67, they don't get it. So how is it possible that I do dermatome testing? The test is telling me no, but the block is telling me yes, because the patient is pain-free. How does this work? And how does this work? And when I do that testing, you get a completely erratic, illogical way of sensory mapping, dermatome distribution of the local anesthetic. So this is very interesting for me, because what it means is something that, once again, we knew for many, many years, and we do it every day. But sometimes you see things in front of your eyes, and you don't do anything about it, and you don't think about it. Because despite there's no logical distribution of sensory mapping of the dermatomes, despite some of them, they got lack of sensation to call that T7, some of T5, some T2, T3. Despite all of that, the reality is that 46% of those patients require zero analgesia. Half of them, zero. And the rest, a minor amount of analgesia. I'm going to show you some comparing studies with other techniques. So it means three things to me. Number one, dermatome sensory mapping is unreliable. Yeah, it's difficult to assess. Yeah, and we have seen is there's no correlation between sensory mapping and pain scores. Think about all of you that you do obstetric anesthesia. You do your spinals, right? You do your testings with ice. And what does the surgeon do first? They test the block, isn't it? Why do they test the block? Because we know that it's not that reliable the way we're testing. Yeah? The final test is with the forceps, isn't it? Pinching in it. That's the final test. So the eyes, and sometimes when you do testing, and you go all the way to T5, T4, T3, but it's still cutting the skin and the woman gets pain. You need to give an explanation for that. And your clinical side of all this, that we know that we need to double check, because we know it's not that reliable. So let's go into the PECS indication so far, and I'm moving a little bit into this. Let me just go back. So far, lots of people are using Pecs blocks, and there's lots of reports I'm going to show you very quickly. And if you want to simplify it, you can say that any upper thoracic procedure that you are thinking about, you could give it a go. You can give it a try. You will get benefit out of it. Not my intention right now to give you the gold standard technique. You can put catheters insertions, and the catheters are dead easy to put, dead easy to do, because they are so superficial, they're so visual. You can know exactly where you put the catheter. And there's no migration issues, there's no any other issues. The only issue is just the surgical side. Yeah? And that's why the catheters, we tend to put them in the PECS 1 space. It's being used for breast augmentations, expanders, and portacaths, defibrillators, anterior thoracotomies, and some of our colleagues in the audience and some others somewhere else for open surgery. And it all makes anatomical sense. The steps to locate it, as I said before, is to locate the muscles that are dead easily seen and see ribs that are very obvious too. Once you do that, if you want to go to the PECS 2 or the modified PECS 1, that is, I would say, the one you should choose out of the three, you go just to the edge and you just locate your rib, this rib 4, and then you lock your needle as close as you can to the rib 4. But what is key in this is either you're locked in the rib on top, the knee on top of the needle on top of the rib. The key issue is that you are in the axillary compartment. You can see here the serratus at this level anterolateral side. In some women is very, very thin. And trying to put your local levar over the serratus can be very, very difficult. But because you are under the axillary fascia, you are already in the right place. So don't bother too much if you blow up the serratus, if you are dissecting above and you are dissecting below. Most of our studies, we did them dissecting above. And if you can do that, that's great. But if you cannot make it that well, you just still put your local anesthetic in there. And then, the reason why I'm telling you that, because this was already published, that in 2011 also, I published that it's very interesting that I can see some kind of effect despite you use it above or below the serratus. So what meant is that once you are there, the contrast spreads all along the rib cage. Not only craniocaudally, but also anterior-posteriorly. So once you hit the axillary fascia or the clavipectoral fascia, that is the medial side of it, you are there. The spread will happen. Now, first lecture today has talked about this paper, and I think you're going to see this many times from now on. Because this is the very first time in a Western magazine, like is Rappan, people are starting with the stage 2 of any scientific method, that is comparing a block against placebo. And as it was properly said before, in this paper that will be published in hard copy in January, you can see the effects in VAS scores of PECS groups in which the VAS score is pretty low, compared with the placebo ones that start much higher and over the time they get better. Interesting in this graphic right now is at 6 hours after, it seems to be that in the PECS group there's a peak in pain. We're moving from 1 to 2 as a mean. And what it means, one thing for you, and something that we all know, that these blocks, they work really, really nicely, as you can see here when the patient gets into recovery, but they don't last long. At 6 hours, they start wearing off. And the more people you talk to, the more people that use them, they all say the same. It's a beautiful block, but does not last long. So it's required to do something else. Interestingly, in this study too, we will see that the paper already shows statistical significance in certain things. The opiate requirements in the Pecs group is half what is in the placebo group. So it's pretty good, and it's statistically significant. Do not expect in any of these blocks, either these or the paravertebrals, to get a 0% for everything, because that doesn't exist. But also the post-op morphine requirements to produce VAS under 3, they were also statistically significant. So yes, that's paper, as well said before, it's an important paper because now it's telling you that this block, it does work. That's something that clinically we knew for a long time. But more things is this. When I show you this, and I tell you that the paper also says that the recovery time is shorter, that the hospital stay is shorter, the nausea and vomiting is smaller, and also all the patients get less sedation, and all the patients that get discharged quickly, from the hospital management point of view, it's the perfect block. And if you think about, I don't know your data about France, but I know that 400,000 women in the United States get diagnosed with cancer every year. Nearly 500,000 of them. And practically 90% of all the procedures they get these days, is the modern type of breast surgery. It's the modern type of breast cancer surgery that is minimally invasive. That means sentinels, tumorectomies, wide excisions, axillary clearances. All those, practically all of them, they're done on a day surgery basis. So they go home on the day. You know that. So the block that is ideally for this kind of surgery is a block that is superficial without any complications. So the vast majority of the procedures will be done under this block. Go back now into, this was, I think, September 2014, something like that. There were some highlights of what was going to happen and what is going to happen in the next few years. These guys also from Egypt. I don't know what's happening with me and the Egyptians, but they seem to listen to me quite a lot. So it's always, when something happens, it's coming from Egypt. Maybe I got some kind of family over there. But anyway, these guys, they just make they jump a few steps. Instead of starting like Rappan did with the placebo, they just jump straight into the question. Yeah, people don't want to wait. So they just said, let's go and compare paravertebrals and pectoral. I don't think that's ideal, but to do that at this stage, but never mind. They did it. They got criticized for doing it, obviously. That's not very popular to do these things. But anyway, they found that the Pecs better in time to the first anesthesia, and also in morphine consumption was better, although it was not significant. Interesting. But also the pain scores as rest were better, and the pain scores with move were better. But never mind, it's just the beginning. So all this is leading to like in a wave. Remember, this is just 3 years. We've been doing Pecs Blocks for 3 years. And if you start Googling and going all around the place, you will see people all over the world reporting, that they're using Pecs Blocks. And the beauty from my side is that it's not me here to convince you that what I do works. It's that all the people telling you, and that's exactly what is the scientific method is about. When people can replicate what you are doing it. You don't need to believe me. But if you got 100 people all over the world reporting the same thing, it makes you think, oh, something is going on here, isn't it? The British, obviously, because I spent nearly 20 years of my life over there, they kind of special interest on me for that. They're also reporting and studying and using some of the pictures for that. And they are reporting the use of Pecs 2 blocks, for all these procedures. And with success, they're claiming some success. Japanese, this one? Now the Japanese are using it for breast synchronization. As you can see, it's going all over the world, from Japan to America special articles about the Pecs block. And what is special about it is not that it's just a block. It's a dead easy block that can be done in seconds. In seconds. You don't need even a minute to do this thing. So, review articles done in which now it's considered that perhaps for day surgery we should use this more often. And some of our colleagues here sitting down in one of the first few rows kind of reporting that maybe we should go a bit more anterior. We should go a little bit more into the obvious, that is the Atlantic coast if you want to discover America, not to the Mediterranean. So, the serratus plane block is the ideal block if you got somebody that you are not comfortable with to do a Pecs 2 block. Yeah? And that was because in some people, it's not stable, it's not, I wouldn't say it's not nice just to stick your probe in somebody's, in women's breast and just start rubbing it around. I thought that was sometimes not really the right thing to do. So we went into doing the designing of the serratus plane block that logically it was going to find another door into the same space. Once again, the blue one tells you the obvious, that any thoracic procedure you can use is, you can try it. And you can see here that a part of the indications that you had before, now you can see something coming up very, very often online, is that people are using it for refractures. During my time in King's College, I introduced the technique over there, and I don't know how it really kicked in so well. And then the refractures idea, now there are some papers on the way from Britain in which they show that they're using it very successfully. And it's got logic behind why using it is, but never mind. We can talk about that later. But the serratus plane block, in reality, when I started using it, was chronic pain blocks, when I was trying to help my colleagues that couldn't do anything else to treat their patients. Some of my colleagues from Ireland and some of my colleagues from Poland, they're already considering to use it for upper abdominals and the Polish for mid-caps. So, be my guest. In this case, this is the latissimus dorsi. You can see it's very easily identified by white hyperechoic strong lines that are very superficial. And then you got the wrist and you got more muscles. You go into the corner and you move into the, here I will explain that in the workshops much easier, okay? But you can see clearly identified structures, yeah? No bony windows, yeah? There's no space you cannot see. Everything is obviously seen, You got the thoracodorsal over there. And you can see your points where you can put your local anesthetic. Yeah? And you can see two muscles open it up. Options above or below, as I said before, still axillary compartment. Results, very small numbers, but the interesting thing of this was the reconstructions about what the local anesthetic with the gadolinium does. And in the reconstructions, you can see a very, very big spread in both sides, no matter where you are, that could be useful for you to use in your setting. In this case, as I said before, for refractures. That's something else. You can see here some volumes, and you can see, perhaps not the colored ones, look into the white ones. You probably are more used to looking to that. You can see that the one that is dissecting about the serratus, you can see how it leaks down much more. Yeah, all the way down, compared to the one that is under, that is like a blob. It seems to stay a little bit more in there. This probably there are anatomical reasons for like insertions of the external oblique, whatever. Also, you can see in the above serratus, you can see goes more posteriorly, something that's very interesting, while the one under serratus is going more anteriorly. Now, you can see this kind of thing that you get. I want to give credit for these people because these are the guys like you that goes into the conferences and they stick the posters into their reporting, new uses for these blocks. So it's not just about me going and publish papers, also give credit to the guys they go into the poster sections and gives ideas and inspiration to other people. So you can see these guys, they are claiming that it does work for ray fractures. This is from New Zealand, I think, and also there are lots of articles, not written by me, but written by others, in which they're reporting, yes, this I use for this. Now even my Italian colleagues, I think, they also did some studies in which they showed that spirometry improves in patients with multiple ray fractures if you do serrated plane blocks. So these blocks, as just to finalize the lecture, and going back to our icon, I just want to clarify the things, because there are three. Maybe you get too confused with so many. And as soon as you start doing something new and novel, you will have another one or another one that we're going to start doing something very similar. So soon you will have about 30 or 40 or 50 blocks saying exactly the same thing. So trying to simplify, that was my aim. So if I want to simplify for you which one to go for first, I would suggest you just to go for the Pecs 2, yeah, because it covers the two compartments. So if you think that you need to block your intercostals, yeah, and you want to think about doing something simple and quick that does not upset anybody around you, think about learning and do the Pecs 2. If you think that you need to work around the nipple, especially, that means a bit lower down than the axillary for the clearances, also think about that, because the second injection, logically speaking, is closer to the nipple. Yeah? And if you think about the paravertebrals, that they are absolutely amazing blocks, but in my view, only mastered by a few, perhaps if you don't feel that confident or you are concerned about things that can happen to you, perhaps you should start just with the Pecs 2, and then with time do the paravertebrals, and then you make your own decisions what suits you best in your practice. So these are my conclusions about thoracic wall blocks for you. So a final thought for you. There's a before and an after for regional anesthesia, and that before and after for regional anesthesia is based in ultrasound. Ultrasound has made a huge difference in all of us. You've seen it in the first lecture today. And many, many, many different things we can design and create thanks to the imaging techniques, because it's always better to see what you're doing. Thank you very much.
Merci Raphaël pour cette mise au point. L'année dernière, lorsque tu as présenté les Pecs, je me suis bien évidemment, dès le lundi, précipité pour réaliser mes premiers blocs. Je crois que tu l'as dit, c'est un bloc qui fonctionne. La deuxième chose, c'est que c'est un bloc qui est facile. Et troisièmement, pour moi, ce qui est important aussi, c'est un bloc qui n'est pas dangereux par rapport au BPV où il y a des complications. Le PEC, c'est quand même un bloc beaucoup plus facile. Après, je suis allé au laboratoire d'anatomie pour disséquer, comprendre un petit peu ce qui se passe. Et je crois que c'est quelque chose sur lequel tu n'as pas insisté, c'est que quand on fait un PEX 1, on est sur des blocs, sur des branches du plexus brachial. Et on est sur des territoires qui sont en principe musculaires. Quand on fait un PEX 2, donc la deuxième injection, sous le petit pectoral, on a en même temps les deux branches des nerfs pectoraux et les nerfs intercostaux. Parce qu'il faut comprendre qu'on a quand même deux territoires à bloquer, un territoire superficiel cutané et un territoire plus profond. La glande mammaire, en principe, dépend des nerfs intercostaux, en principe. On est tous différents, donc bien évidemment, au niveau de l'efficacité des blocs, il peut y avoir des variations. Après, la difficulté que j'ai eue au cours de cette année, et il faut bien que vous soyez conscients, c'est de savoir quel type de bloc pour quel type de chirurgie. 80% des cancers du sein se situent chez la femme dans le cadran supéro-externe. Donc là, c'est vraiment le royaume du PEX 2. Il n'y a pas photo, ça marche très bien, avec des très bons résultats. Après, si vous avez tumo-GS, avec le ganglion sentinelle, c'est la même chose. Vous faites un PEX 2, ça marche. Sur les autres localisations, les autres types de chirurgie, je crois que là, il y a du travail. Et j'attends les auteurs dont tu as parlé. Hein. Est-ce que pour une mastectomie, où il y a un grand territoire cutané à couvrir, le BPV n'est pas mieux qu'un bloc du serratus? Je ne sais pas aujourd'hui. Sur une localisation tumorale du cadran inféro-interne, et ça arrive, c'est rare mais ça arrive, quel est le meilleur bloc? Ça, c'est des questions que je me pose. Est-ce que tu as une idée là-dessus?
Yes, sure. Yeah, I do have an idea. Now, this paper from January right now is the study is done in modified radical mastectomies. There's about 120 cases in which, just not to blur the data between small tumorectomies or wide excisions, they've chosen to use one single operation, that is the radical mastectomy. And I think it is very important because of that, because the comparison with the placebo, showing that you have the amount of opioid requirements plus all the other benefits, it tells you that it does work compared with the placebo, that is stage 1 in any single study. But also, as I mentioned before, and this is just based mostly not in the studies, control studies, it's based in the practice that we knew that when patients were coming into recovery, not following out only mastectomies, radical mastectomies, but also flaps, latissimus dorsi flaps, and major reconstructions. Unfortunately, they are not that often anymore. But we used to put catheters in the PEX 1 area, and we had immediate pain relief. When I say immediate, I mean seconds. And that only could be explained by the theory that all the compartments become ones with a dissection. And it really makes sense, because if you break the fascias, and whatever you put at the top of your pectoral muscle will leak down by gravity into the right or left hemithorax, that local anesthetic spreads there and gets the job done. And that is one of the most simple thought, to think that it's one single compartment. A second thought is how pectoral nerves really work. And that's a thought that is really lots of scientists and people are really thinking and reconsidering the idea that pectoral nerves are purely motor blocks. And more people now they are considering that the pectoral nerves are mixed blocks, because some kind of sensation that by blocking them, you also block, part of the pain that you get from that. So, but yes, in a radical mastectomy, there will be certain areas, especially in the anteromedial part of the hemithorax, in which you will not cover with these blocks that. Yeah? But the answer is very simple. Tell the surgeons to put 2 mils of local.
Avant, quand on cherchait de faire les blocs avec l'ultrason, on cherchait toujours de faire la même chose que le neurostimulateur ou bien le landmark. Et puis là, Blanco, il a ouvert un nouveau domaine qui est excellent à aller chercher. Je trouve ça vraiment bien. Avec les Pecs Blocks, c'est un peu comme avec les blocs cervico-superficiels pour les carotides, ou bien pour les hernies, et puis les blocs ilio-inguinales et puis ilio-hypogastriques. Ce que tu as dit, c'est que tu n'aimes pas trop les chirurgiens. Est-ce que les chirurgiens t'aiment quand tu injectent le médicament dans leur domaine? Est-ce que s'il y a après une évacuation d'hématome ou bien une infection, est-ce que tu as des fois des conflits avec les chirurgiens?
Well, surgeons are very different types, yeah. But the reality is that, yes, surgeons do love me for the type of anesthesia I do, because although initially, first of all, some of the surgeons, they already did some kind of infiltration in the area. And it's very well recognized between surgeons throughout the world that they use some kind of tumor strength anesthesia, basically infiltrate. And the reason was why they're doing that, it was because they knew their patients had less opiate consumption, therefore the patients were not sick at all, and they were completely bright, and they were sent home very, very quickly. So when I first started, I work in several hospitals doing these techniques, and obviously at the beginning you need to explain what you are doing. You really need to explain. And if you got this type of surgeon that is like a wall, no matter how many hours you spend with them, they will still be in the wall. But new generations of surgeons, they're really, really perceptive, and they really realize that to keep their patients happy, what it really matters to them is not to be sick and to be pain-free and send them home quickly. And my patients do that. And the surgeons see that on the spot. So it's easy. So the surgeons like me for that, yeah.
What's your opinion for cardiac stimulator? Pecs 2 for every patient?
The use of portacards and defibrillators is something being investigating for quite a few years by now. Although it was not the kind of regular list I was doing, obviously I got in touch with the people that were doing it, and I suggest them, friends of mine, to give me their experience and their views about is it useful or not. So I think that there's no harm in just releasing information about it, but I've been in touch with a professor of anesthesia of Washington for the last probably 3 years, in which he routinely uses for that, for defibrillators, and also for portacaths. So we're talking about people that with a vast experience in pediatric anesthesia and, you know, in defibrillators for years, 20, 30 years, professors in anesthesia from like that. If they give you a positive feedback and they tell you they have changed their practice, it's something that you need to take on. Second, if you don't believe in the professors from the other side, from the Atlantic Ocean, in our side also, in UK, very close friend of mine, they use the same kind of block for it, and they report a really huge difference. So to me the answer is definitely a yes. People do not appreciate how painful these procedures are, and you know, putting a defibrillator or putting a portacard implies quite a lot of pain. So the more you can do to decrease the amount of pain your patients suffer, the better. And if you got a technique that is simple to use, like this one, compared to others, I cannot see a reason not to use it.
Régis?
Ouais, Raphaël, je voudrais profiter de ta venue. Les blocs, quand on dit sont simples, en fait, quand on discute avec les gens, c'est extrêmement confusiogène, et finalement, PEC 1, PEC 2, PEC 3, PEC X, etc., les gens ne savent vraiment pas quel bloc utiliser dans quelle indication. Est-ce que, par rapport à l'anatomie, alors j'ai compris de l'évolution que tu as faite depuis ces années et les modifications que tu as apportées à tes blocs. Est-ce qu'on ne pourrait pas, finalement, garder le terme de PEC bloc lorsqu'on va bloquer les nerfs pectoraux, notamment lorsqu'on va utiliser des prothèses, et finalement, pour tout ce qui est chirurgie mammaire, lorsqu'on a besoin de tumorectomie ou de mastectomie, finalement d'appeler l'injection dans le creux axillaire, comme tu l'as dit, le bloc du creux axillaire ou le bloc du compartiment axillaire, pour un peu simplifier ces techniques et expliquer aux gens que vous mettez une prothèse, on fait un PEC, il n'y a plus de PEC 1, PEC 2, PEC 3, on fait un PEC entre les deux muscles pectoraux. Lorsqu'on a besoin d'une anesthésie ou d'une analgésie pour la chirurgie mammaire, on fait un bloc du compartiment axillaire, qui soit antérieur ou plus postérieur entre le grand dorsal et le muscle serratus. Après, ça, c'est de la cuisine, mais un petit peu simplifié. Et tu as répondu, dans une des derniers numéros d'Anesthésia, à une lettre de quelqu'un qui, justement, cherchait à simplifier. Donc moi, j'aurais tendance à dire PEC, 6 prothèses, bloc du compartiment axillaire, chirurgie mammaire. Et ça reprend tes travaux, mais en termes de terminologie, d'amener un petit peu d'une clarification pour les gens qui ne sont pas peut-être à l'aise sur ces techniques-là.
Yeah, fully agree. My main reason here is just to simplify things and make it easy. So when it comes into new blocks, and people, sometimes it's very difficult to break through in people's mind about looking at things. And there's always a better way of teaching. And when we start teaching ultrasound, we did it in a certain way. and now we're doing a completely different way. And yes, I totally agree that if the people you are talking to, they don't get the idea, perhaps you can give it a twist to get the idea. But that's only the teaching. My main concern is with starting changing names to the same thing. Because you can see people already, they're changing the name to the same thing. So then you end up like, remember what happened with the lumbar plexus block. You've got about 100 different approaches in which there's just a difference in 1-2 centimeters to the right, to the left, up and down. And it's all the same thing. So we need to look to simplify and just to take it easy, slowly, and keep investigating which block is better for what. Yeah, but we're just at the very first stage. As I say, we cannot compare 50 years of research against 3 of publications, maybe 5 or 6 of researches, and then it looks good. It looks it's going to be good.
Voilà, on va vous remercier. Féliciter Raphaël.